introduce and moderate the talk of Andrea Jungaberle, who is a specialist in anesthesia, in emergency medicine. She's an author, she's a loving and dedicated mother and daughter. She is a medical director of the OVID Clinics. She's a dear colleague. She's good in doing several things at once. She's so good that she is really capable of, or it's necessary for doing several things at once, to do or make quick decisions, to change quickly, and without any space in between all those different tasks. So it is really necessary for her whole being to know boundaries and things going to change from one territory to the other. And that's what she's going to talk about emotional boundaries, knowing boundaries, about doing things, feeling things, thinking things, and especially in herself and in a therapist's self. And this knowing those boundaries is sometimes difficult. And especially as a psychotherapist, where you have to deal with a lot of emotional. No. I'm finishing almost this sentence. Dealing with those emotional boundaries leads sometimes to compassion fatigue, and this is the topic of this talk: emotional boundaries and compassion fatigue. I'm really happy to introduce Andrea. Give her a hand of applause.
Thank you very much, Hans, for introducing me. Hello, everybody. I'm glad to be back here talking to you, and with a little more time on my hand this time than on Thursday in this room. What's love got to do with it? Obviously, I handed in my slides on the days Tina Turner died. And I think it's a really good title because there's so much in there. When we do this kind of therapy, as we will see also later, the dedication, the love we put into it is a very important point, perhaps more than with other kinds of therapy and treatment, but it comes with certain problems and perils, and I would like to talk about this in a minute. So, what I would like to go through with you is the introduction I'm doing now, talk a little about the role of psychotherapy in psychedelic augmented therapy. We've had allusions to that in different talks, like Max's, for example. Advantages and disadvantages of working in clinical trials and the regular clinical application, which is becoming more and more, in my opinion, the elephant in the room. What will we do when we actually get to clinical implementation of these studies, these therapies? The recruiter's wet dream: who would make the perfect therapist for PAT? The topics of emotional involvement and connection, healthy personal boundaries, the risk of compassion fatigue, and managing everybody's needs and necessities. And after that, I'm looking forward to having a discussion with all of you. What is the role of psychotherapy in psychedelic augmented therapy? Right, we've had several takes on this topic, both in the regulatory workshop, in the sessions here, and I think it's not so clear yet, because what we as therapists, as people working with patients, might hope for, and what might actually be also financially feasible when implementing these therapies that are expensive already because the substances will come at a cost and the therapy comes at a cost. And we have a situation today where therapy is already just normal talking therapy, so to say, is difficult to access for many people worldwide, also in Europe. We're in a very privileged position here in Germany and in Switzerland, for example, but other countries have got far more difficulties with that. And I believe that we will have the answer in a few years' time. And the problem is that the criteria on this will be fixed, coming from clinical trials that will only work with certain populations. And once it is implemented, we will see perhaps that working with those patients, we might actually be needing much more than is actually planned for. And how will we get there? What will be the things to do? And I'm just putting this question out there at this point. I actually don't think, by the way, that the mushroom is the therapist. Not at all. So this picture is nice but misleading. I think there's very separate roles between the therapist and the shroom. The substance, the psilocybin, the MDMA, the LSD being a catalyst in a process, and the therapist being the one facilitating this process safely alongside their patients. We're up for a real reality check. Even though the trials we have been seeing in very, very selected populations up until now show a lot of promise, we will see different stuff happening once we're moving this into clinical application. Firstly, you don't see pure pedigree depressed people in real life. They just don't exist. People come with a plethora of problems, symptoms, diagnoses. They have everything on top, from personality disorders to anxiety to, I don't know, eating disorders. It's all there in this package. And it will be interesting to find out how we can address very complex questions these patients bring along with these very streamlined therapies that only have been tested for very small and very highly, massively selected samples of patients. Also, the next thing is, what will happen to the therapists? If this is the case, that this is moving into standard of care, we have a huge problem, to be honest, because suddenly we will be at this. Actually, I have to jump one. I don't need this one. We're at the point where you have people who try to provide this kind of treatment and not within the framework of doing other work. So every 2 weeks, one session, but perhaps every day. And I'm going to come back to this in a minute, because I want to talk about something else to do with this whole notion of, oh, you only need people to supply psychological support. Do we actually need a therapist in the room? This is being discussed for real. Could it be a chaperone, somebody with minor training, a psychiatric nurse or something? And this whole discussion reminds me a lot of my former training when I was working as an anesthesiologist. In 95% of cases, the anesthesiologist is just the nice guy with the coffee stains on his scrubs. Most of anesthesiologic work, 95%, could also be done by a trained monkey. But the problem is the 5% where this is not the case, where excrements in the proverb and this machine here in the middle come into play, and suddenly you're here. You're in highly complicated situations where you have to take very focused, very clear decisions very quickly and intervene, because otherwise people are in deep shit. Sorry for the word, but it's the truth. And this is also true in psychedelic therapies, because you go from sitting next to somebody, looking out the window for 3 hours and thinking about your lunch, to being head over heel trying to help somebody who's having one of the worst moments of their entire life. And I think, keeping this in mind, I do believe we need trained therapists. And my notion would be we actually need people who would be able to work with those diagnoses, with those symptoms, with those problems, even without any substance involved. Nobody should treat things with substances they couldn't treat without. And this should be the standard we hold ourselves to. And of course, there can be teams. There should be teams. And perhaps there will be situations where there's four or five people in adjacent rooms being supervised by chaperones, well-trained people with 1 or 2 specialized clinicians, specialized therapists in the background, going from room to room, helping where it is necessary. Perhaps we don't need this 2-on-1 scenario that we didn't see in the trials now. We have to think broader, also in group therapy, for example. But I think we should not believe that psychological support is enough if things get difficult in these situations. Just to remind us that even if things look nice from the outside and calm, this can be the experience the patient is having on the inside. This is actually Hieronymus Bosch, so quite a few hundred years back. And I think we should be aware that these states can be very demanding, very painful, even if we don't see it from the outside. So the recruiter's wet dream, who are we looking for? Good question. Because what's happening at the moment is that we've got a clear schism. We've got very emotionally open, perhaps overly open sometimes, therapists that work in underground settings. that can be difficult. We've also got academic therapists that are very close to thinking in categories of clinical trials, of questionnaires and so on and so on. And I don't know, who knows this guy down here? Ever seen the series The Good Doctor? Okay, so this guy is actually, the series revolves around a young doctor being on the autism spectrum and his special abilities. So he's a very good person at making diagnoses and treating patients, but he's totally lost when it's about communicating with his patients, actually. And I think what we see at the moment, as we're setting up shop with these kind of therapies, that people come from different directions and they're all somehow extreme. And to me, as I was thinking about who could be possibly a good, the best kind of therapist, actually, I had to think about an office companion of ours that Hans, who just introduced me, sometimes brings along. And that's this chap. So, can somebody guess why I think he's a good example for what I'm trying to explain? Who's got a monkey mind like mine? Nice try, but no. Pardon? It goes a bit deeper. I actually think it's because he's a crossbreed. So this dog is Mio, Hansen's and his girlfriend's dog, and he's an Aussie, so a mixture from an Australian Shepherd and a Labrador. So a Canadian and an Australian dog, which might be a reference to all the colleagues we actually have here at the conference. And he brings together the good, and obviously not only the good, but all the different character types these dogs have. So we've got a herding dog, a very clever one, but one you don't necessarily trust around with kids, and one that's very playful, very happy, but originally bred for hunting waterfowl and bringing back the fowl that was shot down. So two different breeds, and I think if we're looking for the best therapist in this field, we have to become crossbreeds, because people have to be able to both rely on critical thinking, good training, being trained in evidence-based therapies, being able to also put their own minds against what's been theoreticized, and on the other hand, be open, be emotional, be capable of connecting on a deeper level. So my preferred therapist would be an Aussie. I just mentioned it, emotional involvement and connection. Where this, of course, is true for every good psychotherapy. If we look at Graves' criteria that Max was also mentioning, the connection, the therapeutic connection is one of the main factors why therapies work, no matter what school you're from. If you can't make this contact to your patient, you're going to fail them, because you're just not going to reach beyond a certain level of being able to work with them. And also in psychedelic therapies, psychedelic augmented psychotherapies, this is even more important. Why? Well, on one hand, because you have to get people to trust you very deeply to go into those states with you. And on the other hand, because they're so much more sensitive for you bullshitting them. So if you don't have this deep emotional connection, they will feel it, they will be uncomfortable. They might not be able to put the finger into it, but they will be aware at the latest when they go into their dosing sessions, when they have the experience. And this is a great thing, but it comes at a cost. And one of the costs is that it's very difficult to protect your boundaries. When you're so open to connecting with a patient, really keeping this healthy distance, you need to not melt into their experience, especially in a psychedelic state, to still be in the role of a therapist. This is really hard. And also we see, this is something I found super surprising, because this field luckily has been talking so much about protecting patients' boundaries in those sessions when it comes to both sexual or touch-related problematic situations that have been coming up, power balance and all this, but it also happens the other way around. also the patients feel that they are entitled to crossing boundaries towards their therapist in these sessions. They don't mean any ill. They are just in the very open, very transparent, very needy sometimes situation. But for example, a colleague from the episode trial, we have a touch protocol, things we are allowed to offer that we discussed, that we have informed consent about, but the rule is, okay, so we don't offer a hug, for example. But if in a session a patient would come up to you and request one, it's up to your discretion to think about if it's a good thing to go along with that or not. And a colleague in that situation was asked for a hug by a patient, went for it and said yes, gave the hug, and then realized in the situation that there was something off, that he didn't feel well, that he had the feeling there was a certain transgression of boundaries in this hug, that it wasn't as clear, as just wholesome as he would have wanted it to be. And we see this in many other cases too. Like, for example, a very different example. We had the case now that there was an article in a major German newspaper recently where it turned out that one of our patients had been speaking to a newspaper journalist from her screening for the study till a year after without letting us know. So the whole time that we were working with her therapeutically, she had been in touch with the journalist, and this felt very awkward, like touching on our integrity as therapists. Where's the trust balance? Where's the connection that you make and you believe it's both-sided? Of course, she had every right legally to do that, but it didn't really help the trust relationship, and we still, up until now, don't know who it was. It was never disclosed to us. So you look at every patient thinking, okay, was it you who did that? Which also gives a funny feel to many contacts you have with patients. Moving on, the risk of compassion fatigue. Coming back to implementing this as everyday practice. Running a clinic, be it outpatient or in a hospital, is a venture that has to raise a certain margin of profit. Otherwise, it's not feasible. We can't do this for free. There unfortunately aren't millions of funding, euros, dollars out there to fund this kind of therapy. Everybody who wants to take this up has to be aware. And we've learned it the hard way at the OVID Clinic, that this is work that you need to be paid for, and this means we have to do it a lot. How many psilocybin sessions of 6 to 8 hours can you sit a week? Every week, every month, for the next 10 years. Whew. How good will be the emotional connection, the deep care, the real going in there with the patient be if you've done it 500 times in the past 3 years? I've got this inner picture of an old horse in a riding school, just walking in circles and not really noticing much around anymore. And this is the place where we don't want to go. Like, for example, at OVID, if people have a busy day, they have 3 2-hour ketamine sessions they are guiding a day, plus the integration from the day before. That's hard work. Even if you're just sitting there, holding the space, being in there with the patient, takes up energy. And that's why, for example, we advise nobody to work with us for 5 days. It's like 4 days max, because you need to snap out of this, do something else, either be free or do a different kind of work, because it would just not be healthy, wholesome for people. Compassion fatigue is an interesting term for those who haven't heard it. It's used very broadly today. These days, it's about everything to do with not being able to provide proper care because you don't feel the patient anymore. It used to come from trauma therapy and was referring to secondary traumatization of people who dealt with severely traumatized people. And interestingly enough, I've learned recently that there's actually secondary compassion fatigue. So I was a therapist for a patient who was, in her case, taking care of very sick people. She had compassion fatigue, and me taking care of her, I just took the ball from her, and I wasn't sleeping that night. So basically, we should be aware these processes are complex. We go very deep into people's processes with them, and this will always come at a price. So the big task in this will really be managing everybody's needs. There are lots of patients out there who will want this therapy once it's approved. They already want it now. And some of them go underground to get it. And those who are still waiting for us will not be happy if we say, okay, we only can take 8 patients a week for this and that reason, because there will be high demand. But still, we all will be needing to balance their interest towards with our own and with society around it. And there's so many questions, and I don't really have the answers for you. I just want to put it out there. This whole thing about implementing psychedelic augmented psychotherapy it's all good and fine and nice. It's a great idea, but I think bringing this to reality will take many more steps that we haven't even considered yet. Thank you very much.
Questions? Patrick. Microphone is coming.
Thank you, Andrea. Yesterday, Dr. Sarah Bader made a talk about why are some therapists better than others, and also made a maybe provocative but also interesting statement that there should be something, as I understood her, like personality tests in order to see whether people have innate abilities, for example, in relationship building, maybe also in restoration of compassion or something. Do you see this as an interesting idea to screen people before engaging in therapist training?
Well, I think an honest conversation over a mug of tea would be more to my liking than personality testing, because people also can learn and they can be willing to learn. And personality is one thing, but wanting to do a job and going for it is the other thing. And I believe that my feeling is that people who want to engage in this kind of therapy have a very high level of intrinsic motivation. And of course, are you able to hold this is the other question. But in the same way, when I started as a junior doctor, I had no idea I could do the things I did later on. People can develop, but they have to be aware that it's much harder than it looks, that the substances don't do the job for you at all. They sometimes make it even more difficult for you. And that it's really necessary to recheck with yourself if you're still in the healthy area of what you're doing or not.
I was wondering how to solve a kind of or I don't know, organizational problem, I don't know how to call it. The fact that you need so much training, as you stressed, that you need to be actually a good therapist. It's not the mushroom that is the therapist, it's the therapist that's the therapist. You get years and years of training, and then you can burn out really fast, which kind of translates into a very high investment of resources into education and very high risk then of losing someone who invested that and all of the money that went into the education of that person. Of course, we know ways of preventing burnout, but I was wondering if you have any other ideas on how to maybe circumvent that.
I think recognizing that really high quality, intensely oriented therapy for a patient can't really be, so that somebody's work effort can't be measured by the classic standard of a 40-hour work week. But the problem is that our system is still geared at exactly that. And I think our health system in general will have to learn it the hard way. Like in my original profession, almost nobody has got a 100% position, because you just know with the extra time you're doing anyway on top and so on, it's just not possible anymore. And I think it is great to see that healthcare professionals, both mental health and physical health professionals, are actually learning to look after themselves. And especially with this kind of therapy, we are being ridiculous if we're not looking after ourselves while providing this kind of care.
Just one comment. The looking after myself, of course, that's important. But also I have expectation as someone who invests so much money, my money too, and time into my training. I would have an expectation that somebody also takes care of me, as you said, that we cannot have or all of us, that we cannot be expected to work 40 hours. I know I can't. So I can take care of myself, but I would also like somebody to take care of me systemically.
There we are in a very different problem, that we have fewer and fewer trained specialists because of the demographics and so on, and because people don't put up for such a long time with this kind of stress anymore, they quit earlier. And I think there will be systemic change needed, but I don't really know if this is the place where we can start bringing it about, but having the awareness that especially if you try to provide high quality, deep work with patients, this has to be done from a place of, strength, not just willpower.
There was a question in row 4. Yeah. Here, down here.
Thank you, first of all, for the talk. You said that nothing should be treated with substances that could be treated without. I got that right? No? Did I get that wrong?
What I was trying to say, that a therapist who wouldn't be able to treat a certain condition without substances shouldn't be treating it with substances.
Okay, then my question just dissolved. Thank you. Well, I actually have a second one, if I might. Is there any way of, or like any other way of protecting your resources other than making the treatment so expensive? Like, for example, with the ketamine therapy that you offer at the moment?
It's a very good and very difficult question. I don't think we're protecting the resources by the pricing. We're paying the rent by the pricing. And this is something that needs to be done on this level, as long as it's fully in the private sector and out of pocket. If the health services were assuming a certain, will to contribute to this kind of therapy, this would already change. In my ideal world, this kind of treatment would be accessible to everybody, from the, Ukrainian refugee to the Syrian janitor to whoever. And at the time being, where we are now, it's not the case. It's for the few and fortunate who can either pay private insurance or have the money in pocket to pay for it, or the grandmother or sugar daddy who does. It actually happens. And it's really important to just keep an eye on all that. And I think new emerging strategies are rarely implemented very broadly, but we have to make sure that these therapies get to the people who really need them.
One more question, yeah? No.
Yeah, thank you. One more question from the online audience. Could you mention specific characteristics needed to be a good psychotherapist in the psychedelic field?
Oh boy. Right. It's not so different from any other requirements for being a good therapist. We are not reinventing the wheel, we're just adding some new cogs. So basically, if somebody is able to empathize with a patient, is able to be in good contact, is able to understand processes without getting over-involved, being able to control your own triggers, all these things that are normal for everybody working as a therapist. It's like a little more intensely that, but not actually that much more. I really think the general will to be helpful and in touch with another human being to their benefit without elevating yourself, it's just at the core of it all.
Important last point. Although you might want to be helpful, sometimes it's best to just step back and do nothing, and that can be quite difficult as a psychotherapist. Thank you, Andrea Jungaberle.